let's begin with today's topic. Now, in this picture, you're seeing two gentlemen. One on your left is a typical old grandpa who's crouched using a walking stick to walk. And on your right, you've got a similar aged guy, but he's looking completely different. He's on a cycle. Let me tell you, he's my teacher. And this is a picture when he just cycled from Bombay to Alibag non-stop. So the question remains as who do you want to be in today's generation? Would you want to be like the old duck in the left, or would you want to be an active, fit old guy? So things in today's generation are changing. People are wanting more and more to do with their lives. Things are changing from palliative treatment to preventive treatment. Now, nobody is talking about how to cure cancer. People are like right now thinking, how do we avoid cancer altogether? Same way, life-saving procedures are reducing, and right now more and more procedures towards changing the quality of life is happening. So the people's perspective is changing. So what is the difference between the previous and the old? It's not the age, because both are of the same age. Then what's the real difference? Is it the gender? Is it to do with their genetics? Not really. The main difference between the two is the quality of their bone and their muscles, which is somewhat interlinked, and that is what I'm going to talk to you about. But before going to the topic, basic understanding of how the bone works is important. So as an analogy, a bony cycle is just like a building under construction. There's constant generation, regeneration, something new, something subtracted, something added, that keeps going on. So let us have a cross section of bone. So if you cut open a spine or a bone, this is how it is going to look. It is typically made up of columns, beams, and mineral. So it technically it's something like how your wall is. It has got columns, it's got beams, and it's got cement which is put inside. So that's how a normal structure of our bone is. You must have heard about a condition called as osteomalacia. Now, osteomalacia is typically where the quality of bone is going to reduce, which means what is going to happen is that the structure of bone is going to remain the same, but the calcium inside starts going away, which means it is similar to you having a wall wherein you have laid in the bricks, but you have not put in good amount of cement. So basically the yellowish bit went away, and that is basically what osteomalacia or demineralization of the bone is. Osteoporosis, on an other hand, is a completely different condition. Osteoporosis technically is a disease of the bone, wherein what happens is there is just not the loss of mineral, but you lose the lattice itself, which means it's not just that you have forgotten to put good amount of cement in the wall, you've also not put enough amount of brick. So on the left hand side, you can see a representative structure of the bone, wherein you can see the lattice or the structure of the bone, which is filled in with all these black spots, which is the calcium or the cement. Whereas on the right is a osteoporotic bone, where you see that both the structure and the cement have reduced. So what essentially it does, it diseases the bone and it makes it liable for fragility fracture, or basically it makes it like something like a biscuit where you do this and it is going to break. So basically what happens in osteoporosis is there is loss of bony lattice, which means there is change in the quality of bone altogether. On the left, you have got a normal bone, and on the right, you see a bone of a 75-year-old lady with osteoporosis, where you don't have the structure, neither you've got the calcium inside. Okay. So that's basically what osteoporosis is. Eventually what happens is whenever pressure starts coming, these bones which are structurally weak starts collapsing, and that is basically called as insufficiency fracture. Insufficiency fracture are fractures that are happening in bones which are diseased, either because of either osteoporosis, or it could be because of some other pathology. The dictum is, if a person is falling down from a standing height, that is called as trivial trauma according to the WHO definition, and a person who sustains fracture with a trivial trauma is most likely because of an osteoporotic fracture. All right, so let's discuss a bit more about this, about osteoporosis, and I'm going to throw in a little bit on, I'm going to touch how to treat osteoporosis. Now, the question might come in as, why are we talking about osteoporosis? Because a lot of times you don't understand that the results of a treatment depends upon a lot of things. The two important things where the treatment depends upon is the quality of the bones and the quality of the muscles. When the quality of bone becomes bad, that is the condition called as osteoporosis. Whenever a person gets osteoporosis, the muscles also becomes weak, and this condition is called as sarcopenia. So osteoporosis and sarcopenia come hand in hand, and when we are treating any orthopedic problem, you need both qualities to be good. Now next question comes as, why am I talking on osteoporosis? See, the important bit is that osteoporosis first is seen by those people who are treating the problems arising out of it. And the biggest brunt of osteoporosis happens in the spine, followed by the wrist and the hip. So these are the doctors who are in direct touch with these patients, and hence we are the ones who are talking about osteoporosis. So let's just 1 second. Kindly refrain from annotating. Yeah. So now many things can actually interfere the development of your bone and influence how the quality of your bone or skeleton is going to be. Okay. It could be genetic abnormalities. It could be nutritional deficiencies. It could be hormonal disorders. These are the things that causes some kind of bone problem. So some can be tall, some can be short, some can be fat, thin. You've got people who don't have good bony development, or who have got deficiency of bone production, like osteogenesis imperfecta and such congenital conditions. And there are other conditions like thyroid deficiencies, which indirectly affect the quality of your skeleton. But the most important and the most commonest bone disease is osteoporosis. So just to give you an idea about how bad osteoporosis is hitting us worldwide, and this is facts coming from literature, worldwide osteoporosis causes more than 8.9 million fractures annually. So technically there is one osteoporotic fracture every 3 seconds. Technically that's more than the speed with which the corona is spreading. Osteoporosis is estimated to affect around 200 million women worldwide. Approximately 1/10 of the women above the age of 80, above the age of 60, 1/5 above the age of 70, and 2/5 above the age of 80, or more than half of the age above the age of 90 are going to be osteoporotic. Now, why women? Is because overall osteoporosis tends to hit women maximum. Now, women have got that extra hormone called as estrogen, which is beneficial in a lot of ways. It prevents them from cardiac problems. It keeps the bone healthy. But as soon as they hit menopause, there's a sudden dip in your estrogen level. That's why that influences the bone quality, and hence it is the women who are hit with osteoporosis fastest. There's also other environmental fractures which are associated with it, which we'll talk about. Yeah. Now, in the year, overall, around 75 million people in US, Europe, and Japan in total are affected by osteoporosis. In the year 2000, and that's like 20 years back when all of this was happened, there was an estimated 9 million new osteoporotic fractures. Europe and America accounts for around 51% of all these fractures, whereas the remaining happen in the West Pacific and the Southeast Asian region. Which means that osteoporosis is as important as diabetes and and breast cancer and blood pressure. So it's not something that we can ignore, and it's coming on our face every day since the activities are increasing. In overall, 1 in 3 women over the age of 50 will experience osteoporotic fracture, and 1 in 5 men are going to get that. So a lot of us who are right now discussing on this and hearing all this at some stage in our life are going to get osteoporotic fracture. Overall, 61% of osteoporotic fractures occur in women, with a female to male ratio of 1:1.6. Around 75% of fracture occurs amongst 65% year group or more. 10% of bone mass in the vertebrae can double the risk of vertebral fracture. So, which means that if your bone quality just deteriorates by 10%, you're at double the risk of developing a fracture. It is projected that about 50% of all osteoporotic hip fractures will be in Asia by the age of 2050. In a study amongst Indian women aged 30 to 60 from low income group, BMD reported that as compared to the developed country, there is higher prevalence of osteopenia and osteoporosis in our country, which means that Indians are at a higher risk of developing osteopenia and osteoporosis. In 2010, an international report in the Asian audit by International Osteoporosis Foundation had predicted that India would have approximately 36 million osteoporosis patients by 2013. But more serious was the fact that Indians are prone to fractures at a much younger age than their Western counterpart. The endocrinologist Dr. Amrish Mittal, who was a man who actually got the first bone density machine in India, predicted that 50% of the world's fracture were expected to occur in this region by 2050. The idea of throwing all these statistics on you is basically to prime you how much of a serious problem osteoporosis is going to be. And all of us are at that position where we can identify and treat osteoporosis quickly and effectively. Again, eventually towards the end of the lecture, you'll realize how important it is to follow correct protocols in treating osteoporosis, because these patients, before going to the endocrinologist, before going to the physician, are going to come to you and me. So it's up to us to identify them. Yeah. Now, the combined lifetime risk of hip, forearm, and vertebral fractures coming to a clinical attention is around 40%, as good as a cardiovascular disease. Also, osteoporosis takes a major economic and personal financial burden, because whenever you get osteoporosis, overall your productivity goes down. If you land up with osteoporotic fracture, that's an added expense, and that hits the entire family. So lot of places, especially now, even in our country, where public health is given importance, they look at how much a disease is going to cause problem to the community. And essentially the disability due to osteoporosis is greater than that is caused by cancers, or is as good as any other disease such as rheumatoid arthritis, asthma, and high blood pressure. Now, you know about all these things, so you should know about osteoporosis also. In women around 45 years of age, osteoporosis accounts for more days spent in the hospital than many other diseases, including diabetes, myocardial heart attacks, and breast cancer. It is estimated that residual lifetime risk of a person experiencing an osteoporotic fracture in men over the age of 50 is up to 27%, which is higher than the risk of developing prostate cancer. And prostate cancer is one of the biggest screening campaign that happens in men. So if you are treating blood pressure, if you're treating diabetes, if you're treating heart problem, you have to treat osteoporosis. You don't leave it as a secondary disease, not giving them a lot of importance. All right. So let's say these are the commonest things that we hear about osteoporosis from. Even sometimes we think, or our patients talk about it, that, doc, I'm taking calcium, I'm not going to get osteoporosis. Or some person comes and says that, doc, do something, my knee has got osteoporosis. So here are some facts about osteoporosis. One, osteoporosis is not calcium deficiency. Okay. Calcium is not the treatment of osteoporosis. Remember what I told you about the bone mineral and the bone mass. So again, just recapping, imagine you have a wall. A wall has got bricks inside, and on bricks you are putting cement. So a wall with good amount of bricks and good amount of cement is a normal bone. You remove the cement from that and your bone mineral goes down, and that is osteopenia or osteomalacia, where the quality of your bone is the calcium content of your bone is going down, but the structure of the bone is still the same. Condition where, apart from the cement, you have also removed some bricks. That is the condition where you get osteoporosis, because then how much ever cement you're going to put, if there's no bricks, the cement is just going to wash away. Similarly, how much ever calcium you load in a person with osteoporosis, it's not going to have any value, because the calcium is just going to get washed away. Second, osteoporosis is a generalized disease. It is not like you have osteoporosis in the wrist or you've got osteoporosis in the spine. It is affecting all the bones of your body. The fractured bone is just where you can actually see that disease with your eyes. Means the disease has caused a problem and you're identifying it. Does not mean that your the bone of your skull is normal. Even that has gotten weak. So it's a generalized condition. Again, the last bit is osteoporosis has got no cure. That is why it is very important that you identify it early and prevent it, because prevention is the only true treatment of osteoporosis. Okay, that is why early diagnosis is the most important step in treating osteoporosis. We guys are at the position where we can identify, counsel, screen, and test the patients for osteoporosis, and if detected, treat them aggressively. Okay. Yeah, just give me a second. So how do we diagnose osteoporosis early? So here what you have to do is clinically identify the patients who are at risk to develop osteoporosis, or someone who's complaining of these generalized aches and pains, generalized feeling of tiredness. Doctor, इधर भी दुखता है, इधर भी दुखता है, कमर भी दुखता है, पीठ भी दुखता है, ताकत नहीं रहता है, थकावट लगती है. These are the patients who are giving the history suggestive of a generalized bony problem. Or you identify those patients who are at risk. So patients who are taking, there is a big chart, but in general, patients who are taking steroids for a long term, patients who are fat, not really exercising a lot, are having a very sedentary lifestyle, has had history of fractures, are taking certain medicines which are prone to cause osteoporosis. So these are the patients. Clinically, these patients typically present with progressing kyphosis or generalized hunching. You will see that they have got muscles which are flabby, and overall the posture is ekdam weak. So these are the patients that you look at them and then you start thinking that, okay, maybe this patient has got osteoporosis. So a lot of patients who you all are treating for back pain who are not getting better in spite of everything that you do, maybe you have just missed out the fact that the patient is purely osteoporotic, which means the patient has got sarcopenia also, which means that the bones and muscles are weak, which means how much ever you treat them, the muscles are never going to get strong and their back pain will never go away. So this could be that one missing link in your treatment. That is why you identify the patients who are at risk for osteoporosis. What do you do then? Once you know that, okay, chalo, these are the risk factors, then you need to have some objectivity. Just because I said that the patient has got osteoporosis or some x-ray saying osteoporosis, does that mean that the patient has osteoporosis? Not really. So there are just two investigations which are there, which have also recently come up and we are looking at it, is Dexa Scan and Quantitative Ct scan. So these are the two investigations which objectively can tell you if the patient is osteoporotic or not. Yeah. Just to give you an idea of how much the osteoporosis gets unrecognized, this is a series of patients. So what in this study it was done that around 930 women who are above 60 who were hospitalized for other causes other than spine related back pain. Yeah, they usually get chest x-ray done as protocol when they get admitted, and on seeing the chest x-ray there were around 130 odd patients who already had fractures, and there were 52% patients who already had some kind of some kind of mention of osteoporosis, which means up to more than 50% of people are roaming around without being recognized as patients of osteoporosis, which means that incidentally when you're doing an x-ray you suddenly see, array, the patient has got a very poor bone quality. So a lot of times even we when we get an x-ray done for some other thing, we see and we tell the patient, yeah, everything is fine, but I also see that your bone quality is bad. So that is why you should have a very high index of suspicion and you should have your criteria set as to which patients you are going to investigate for osteoporosis. Now, in my practice, what I usually, sorry, just 1 second. Yeah. So in my practice, usually every patient who is above the age of 50, females, and every patient who is above the age of 60, male, coming to me, I counsel them and I tell them to get a bone density report done, because it's my duty to educate people and try to pick up those patients. So I would also encourage you all to do that. Every patient above 50 who are females and 60 who are males should be at least screened once for osteoporosis. So you just tell them to get the bone density done. Now, who are those at-risk subjects? I just told you about this. There's a list of conditions where osteoporosis are seen. But for you, it's just very simple. Just identify those two patients or patients with generalized aches and pains or who are kyphosis. Sometimes the patients might also give you a very funny history that I feel my mom's height is reducing. Okay. You might laugh at that, but that actually happens. People who have osteoporotic fractures slowly and steadily become kyphotic. So slowly their height actually starts decreasing till overtly you can see kyphosis, and then the people know that they have started bending. So these are the histories that you have to look for. Once you have identified those at-risk patients, you send them for a bone density scan. So bone density is basically a dual energy X-ray absorbimetry scan, which means Dexa scan. It's a simple, easily available, relatively cheap test, and it's not something where you put the patient through a tube, which means it's relatively open. So it does not cause claustrophobia. It is a very good screening test, and it can also help in determining the response to treatment. Yeah. Sorry, just a sec. So here, once you do the Dexa scan, what do? Is we get two values. One is the T score and Z score. So let's say they have done a bone density of me and they have found some value. That value they are going to compare with normal healthy subjects, and they will tell how bad is my bone as compared to the normal healthy subjects. Okay. Z score, on the other hand, will measure my bone quality with someone who they consider normal of my own age. So technically, and so these are the technical aspect, but practically it is the T score that we are looking at, because we want to compare ourselves with the normal healthy. Okay. So you get a T score of minus 2.5, which means that as compared to someone who is normal, my bone is minus 2.5 times bad. So technically, when your T score is less than minus 1.5, you're considered to be osteopenic. And when it becomes less than minus 2.5, then you're considered to be osteoporotic. Okay. But there is a problem with osteoporosis, problem with bone density. One is that it's not like you start treating osteoporosis immediately, there's going to be a change in your bone density. So it's going to take time. Hence, you are not able to immediately monitor if your treatment is working correctly or not. That is first flaw. The second flaw is bone density basically is rays which are passed through the bones, and they are collected, and the quality of the bone is determined. In a severely degenerative spine, what happens is there is a lot of movement that is happening that causes osteophyte formation. If there is severe degeneration, severe osteophyte formation, which means there is a lot of new bone formation. So although the patient might be severely osteoporotic, your bone density will come normal. Hence, when you do bone density, you just don't screen the spine. You see three places which are affected the maximum. One is the spine, one is the hip, and one is the wrist. There is no role of full body DEXA. These three areas are good enough. If suppose a patient has been operated at a particular area, that area you have to just mark. You don't consider that area, whatever the reports are. Okay. And if you have got a very degenerative spine, so 80-year-old person showing T score of 1 is something abnormal. There you see the X-ray, and if you see that there is severe degeneration, don't look at the spine. You look at the wrist, and you'll realize the wrist is minus 4.5. Okay. So that is the second problem. Now, the other thing is that not necessary an increase in BMD may not be an adequate surrogate marker of efficacy of all treatment, which means that even if your bone density quality is increasing, it is not just one second. Yeah, so you're not really sure is how much it is going to translate as a practical relief to a patient, which means your bone density might improve from minus 4.5 to minus 2.5 or minus 2, but that does not guarantee that he will not have fracture. So these are the fallacies of the investigations for bone density. So what else? There is another much more specific and better investigation for identifying bone density, and that's qualitative CT, which means you do a CT scan of the spine and you actually study the sections and see how much is actual bone density. So it will give you an accurate idea about the quality of bone. So that's one of a that's a very specific test. But the issue is that till now we don't know what is normal, which means if a QCT says that there is 30% bone density, what does that mean? Is it normal? Is it low? It is high? So we don't still have the baselines yet, because there are a lot of ethical problems in doing those studies, unnecessarily telling normal people to undergo CT scan. So that's still in progress. So as of now, the best possible test that you have to identify and evaluate and eventually monitor the treatment of osteoporosis is bone density. Okay, whenever you ask a person to do a bone density, ask them to do it after stopping all calcium supplements for at least 4 days. Okay, and tell them that you need the bone density level at the hip, at the spine, and at the wrist area. All right, so just before we start with the treatment, I have one urgent thing that I have to look at. Sorry, some urgent messages. Yeah. So now once we know, once they have identified, once we have quantified everything, now we need to treat osteoporosis. So and as I told you, osteoporosis is a disease of the bone, which means that it is a medical problem, which means it has to be treated with medicines. All right. So the different treatment modalities are hormone replacement therapy. Then you have got raloxifene, calcitonin, bisphosphonates. There are newer medicines which are there. There are certain hormonal therapy like parathormones and strontium. So these are all the treatments that you have. Out of this, hormone replacement therapy and raloxifene and strontium, that has reduced or that has gone into disrepute, because when we started identifying the pros and cons of this versus that, we realized that the side effects of all those therapy was way more than the effects of those therapy. That's why they went into disrepute. And today, the three medicines which are used to treat osteoporosis are calcitonin, you've got parathormone analogs, and you have got denosumab. Yeah, not bisphosphonates. That is the main difference, which also I want to understand. So tell you guys. So a lot of people say that I have been taking Gemfos or I have been taking this medicine for so long, so I've been treating osteoporosis. Well, that's not the fact. Every medicine has a different way by which it acts on the body. So the first treatment which came into became popular and went into disrepute was hormone replacement therapy, because they started seeing that a lot of cancers started worsening or started the incidence of cancer started increasing in females who were taking hormone replacement therapy. Somewhere to do with the fact that the chances of breast cancer before 50 and after 50 varies, because mainly it has to do something with the estrogen hormone. Similarly, when you're giving hormones to a patient, you are bound to have side effects, and one of the side effects was cancers. That's why it went into disrepute. On the other hand, the things that we are using now are nasal sprays, which is one of the first and the easiest treatment. It is essentially a calcitonin nasal spray, which basically acts by inhibiting osteoclastic activity. And it has some action on the osteoblasts, which means that it demonstrates new bone formation effect due to direct anabolic action. Also, it has got a painkiller, somewhat of a painkiller action, means analgesic action. So what does this really mean? Now let's consider a bone. If you've got this bone, you have got osteoclasts which are there, which will come and which will eat away the bone and take the calcium and throw it into the blood. You have got osteoblasts which will take the calcium and reform the bone. Okay, so this is why the bone is constantly undergoing a cyclical change, thus like a building under construction. That is why when you use calcitonin nasal spray, it has action on osteoclast, which means it will stop the body cells to remove calcium from the bone, and it will stimulate the osteoblasts to deposit more and more calcium. Now the question comes as to why does the body want to do something like this? So calcium per se is very important for natural functioning of all of our cells, which means if your calcium in your blood goes down, your cells are going to start acting haywire, and one of the effect that will happen is you will end up getting a heart attack. That is why body has to primarily maintain the blood calcium level as normal. That is why a lot of times when people say, I don't have osteoporosis, my blood calcium is normal, the blood calcium is always going to be normal. That is the job of the body. That is why when you take in less of calcium, what happens is the body is taking away all the calcium from your bones, and the quality of your bone starts depleting. That's why throughout life after 50, you need to put a patient on a basic calcium supplement, so that at least you are artificially giving calcium and keeping the blood calcium level all right, so that at least the bones don't get destroyed. So calcium after 50 is not to treat osteoporosis, but is to prevent osteoporosis. Okay. Next, so primarily it is used in patients who are symptomatic patients with osteoporosis. Why? Because of the third property, that it also has a pain killing effect, which means a patient who has got osteoporosis and has a fracture or has bony pains, you give them, it really helps reduce their pain. And it also given in young patients. So nowadays we are also seeing young patients with low bone density value. So in young patient, it really helps a lot, and of course has a painkiller effect. It has a quick action. It is given through your nose, and the only problem is that you cannot give it more than 2 months, because after 2 months it develops an antibody to the. So basically, what is this calcitonin? It is basically an artificial animal derivative that you're putting in your body, and it is stimulating your bone production. Your body develops antibodies to it, and at some stage it stops working. That's why you give it only for 2 months. Yeah. The other is bisphosphonate. So as I told you, the treatment of osteoporosis is only three. There's calcitonin, you've got denosumab, and you've got teriparatide. But the most commonest treatment of osteoporosis given all around is bisphosphonate. Now, bisphosphonates are basically alendronate, residronate. In a trade name, it is called as Fosavans or Gemfos and all Hydrofos, all these things. Yeah. But they are not to treat osteoporosis. They are medicines to prevent osteoporosis. So its action is not to stimulate bone deposition. It only inhibits the osteoclasis, which means the osteoclasts, or those people who are removing the calcium from the bone. Bisphosphonate is going to go and stop them. So in a normal bone, when you give bisphosphonate, then it will prevent it from becoming osteoporotic, or it will delay the spread of delay the time by which the patient will really become osteoporotic, but it will not reverse the process. Understood? That is why up till now nobody bothered with osteoporosis, is because up till now the only treatment stopped here, and that is bisphosphonate. And if you don't have a treatment for a particular condition, then what's the point in treating that, or what's the point in even talking about it, right? So if suppose you don't have treatment, Dexa करके क्यों time waste करने का? That is why our previous generation, so our great grandparents or our grandparents, if you see, are all crooked like this, is because when they were growing up, there was no treatment. We are in the era where we can identify and treat osteoporosis. So up till now, we just discussed on identification and preventing osteoporosis, right? The actual treatment is reversing osteoporosis, which now for the past 10 years we have started, and now it's become safe. So that I'll talk to you a little bit in detail. But bisphosphonates you all need to know about, because that's the first line drug. And every patient who becomes osteopenic, which means every patient who on Dexa shows minus 1.1 or worse, should be started on bisphosphonate, because it is effective, it is compliant, it is not expensive, it is safe, except there is just one problem, and it causes a lot of gastritis. So every patient who we advise bisphosphonate is supposed to be told that you take it once a week in the morning, and you take it on an empty stomach with cold milk or cold water, and at least 1 hour, don't lie down, otherwise you'll get a lot of gastritis. Okay, so that's bisphosphonate. It's a good startup treatment in osteoporosis, especially the post-menopausal women so a lot of gynecologists just start this for their patients as a preventive treatment. It works well till the bone stock is not very low, essentially. And there are certain conditions, like I don't want to confuse you, but there are certain conditions where there's a very acute bone loss. Those patients, bisphosphonate is going to help you a lot. So also, most of the studies that were done was done on the weekly dosage of bisphosphonate. So don't get carried away and try to give one injection a year or once a month injection. All the studies have happened at the weekly dose, and that's the most effective and the most safe way of giving it. And that's called as alendronate. Okay. Trade name is Gemfos 70 milligrams or Fosavan 70 milligrams. Okay. These are the advantages of bisphosphonate. Is effective, widely applicable, good compliance, safe, and relatively cheaper. Okay. What about patients who have already got osteoporosis, which means their bone quality is already bad? The workers have come and taken away the brick over there, and now you are in a position to put in cement. But how to regenerate that, right? How to change and get the previous structure of the bone so that the calcium can get absorbed correctly back. That happens by two medicines, and that is teriparatide and denosumab. So this is the major change that has happened over the past 10 years that has made us capable of treating osteoporosis, right? So teriparatide or PTH in regular dose causes bone resorption, okay? Which means there are certain conditions like Brown's tumors, which secretes PTH, which causes bone to be resorbed, which means it worsens the osteoporosis. But if suppose we give it in a smaller dose and in a pulsated dose, which means single small dose at a regular interval, which means every day regularly for 1 year, ideally for 2 years, will stimulate bone production. And this is the only drug which can reverse and cause osteogenesis. Okay. So how is it different from bisphosphonate? Just conceptually to understand is, if you have a normal bone, that bone in osteoporosis gets resorbed. When you treat that patient with bisphosphonate, what it does, it prevents the further loss of bone, but it is not going to change your quality of the bone. Whereas if you treat the same patient with the help of teriparatide, what it does, it builds up the quality of the bone, one, and then the calcium deposits on that, and overall the end result is a very strong bone. So that is basically the main difference between preventing and treating osteoporosis. I hope I am clear as much as I could help you out with, right? There are other drugs also. So now teriparatide is a very safe medicine. It is similar to insulin, which you take every day. It comes as a pen vial, which you have to inject. Okay. These medicines range from 3,000 to 4,000 to around 20,000 a month. So it is expensive, and there's a great variation. Now, great variation is because all the studies have been done on the drug by a company called as Eli Lilly, and the trade name is Forteo. Okay. And then you have got Indian companies which have, copied it and made it into their own versions. All right. It is not the drug or the company that's different. The problem is the effectiveness of the treatment depends upon cold chain. So this is actually a hormonal treatment, which means right from the production till the patient ejects it, it has to be maintained at a particular temperature. All right. So not all companies are, compliant with the norms. That is why some drugs, some injections, although they are very cheap, okay, you don't get the results. That's why we always advise that if you are affording, then you go for the original molecule, because as clinician, we have visually seen a gross difference between the result of Indian and the imported ones. All right. So here it is important to stick with the original molecule. Yes, of course, if the original molecule, if they are not affording, then you better give them the Indian molecule and make sure it's of a reputed company. Now, why so much fussiness is because there is a time frame. you cannot give this medicine for more than 2 years. All right. Which means you start taking this medicine, you can take only a total of 2 years course. Beyond that, it is not safe to take this medicine. That is why you don't want to mess with it. You want to give the best quality. Also, the best effect is seen if you take this medicine every day for 2 years. I usually give it for 1 year and reassess the effectiveness of treatment. But the ideal protocol is you give it straight for 2 years, and then once the bone quality is built up and the quality is good, then you stop bone loss by putting in bisphosphonate. All right. So up now, that is teriparatide, and that is working only for 2 years. What about patients who are partially treated but they still have osteoporosis? They have not gotten totally better. What to do for them? 2 years of treatment is already done. So newer medicine called as denosumab has started coming in, and denosumab is a newer generation medicine that helps in osteoporosis. And the advantage of this medicine being that it has to be taken as one single injection every 6 months, and it is seen to be safe for up to 10 years. So the only disadvantage of denosumab is that it does not take care of sarcopenia, which means that when you treat osteoporosis with teriparatide, along with making the bone strong, it also makes the muscle strong. Whereas denosumab will only make the muscle strong. So you identify a patient. If the patient has got osteoporosis, you start giving them injections of teriparatide and make sure that they take that for 2 years without break. After 1 year, you repeat the Dexa and you see that is improving. If there's a substantial improvement, you can stop the teriparatide and shift to denosumab and keep that 1 year of teriparatide for a later date. If there's not a substantial improvement, you continue with the teriparatide. Okay. Once you shift to denosumab, you have to give it straight for till the time the bone density value improves. And once it is shifted from osteoporosis to osteopenia, that is the time you stop all of this and you shift to bisphosphonate. Now again, bisphosphonate you can give safely, but you cannot give it unendingly, which means you have to give it for a maximum of 4 years, after which you need to take a drug interval of 6 months. Otherwise, there are known that the subtrochanteric fracture of the hip drastically increases on a patient with long-term therapy of bisphosphonate. That's why you need to have a disease-free interval when you're treating a patient with bisphosphonate. All right. Multiple different trials were done, and after that, it has come that denosumab has now started emerging as a first-line treatment for osteoporosis, followed by teriparatide and prevention with the help of bisphosphonate. This is the medical basis to it. But apart from this, there are also environmental fracture that actually influences your bone quality. So diet is important. Just treating with hormones is not important, is not enough. You have to load yourself with calcium and vitamin D both. All right. Sunbathing is not enough for vitamin D, because in Bombay and in metro cities, the smog is so bad that you will not get that much good rays to develop good vitamin D from your skin. So vitamin D is important. Calcium is important. You need to take 1000 milligrams of calcium every day in a person with diagnosed osteoporosis, which is equivalent to 500 milligrams of elemental calcium. Never give vitamin D supplement without calcium. It is of no use. All right. But you can give calcium without vitamin D supplements. Apart from this, you need to be involved in certain physical activities, and because not exercising and not being active for long period increases the chance of osteoporosis. uh, like muscle, bones also become stronger and stay stronger with regular exercises, and these exercises should be a loading type of exercises where there is actual load that passes through your body, which stimulates the bone production in the areas of the load bearing axis, which means something like jumping, jogging, these type of activities. uh, this is one condition which does not like you to be size 0, which means if you're too slim, then you better eat something, because it's seen that people who have very less BMI are more prone to osteoporosis. Smoking directly affects and causes osteoporosis. And again, alcohol, people who are alcoholics or who drink a lot are more prone to getting osteoporosis. So essentially the idea is that you should age gracefully, you should keep fit by identifying, treating, identifying, and if needed, treating osteoporosis, and coupling that with endurance building activities, exercises, and weight training. So the take home is that basically make the most of your growing years, recognize osteoporosis early, institute treatment early. Don't wait for it to happen. Treat it right in the beginning. All right. So that's basically